Psychological distress rarely survives on its initial injury alone. It builds a system. Anxiety and depression construct self-perpetuating feedback loops, patterns of thinking and acting that actively defend the distress against anything that might relieve it. Aaron Beck recognized this dynamic when he pioneered cognitive behavioral therapy. He observed that depressed and anxious patients actively sustain their distress through behaviors like rumination, withdrawal, and avoidance. These patterns prevent them from encountering experiences that might prove their negative beliefs wrong. This flowchart illustrates the CBT maintaining cycle. It maps how thoughts, emotions, and behaviors continuously feed into one another. But it also includes a fourth critical node, the environment. The outside world is the stage where these internal cycles interact with external reality. The environment is the structural vulnerability of the entire system. It is the only place where new, contradictory evidence can physically collide with a patient's assumptions and break the cycle. CBT relies on this external friction to force an update to the patient's internal beliefs. Therapeutic change depends on the world pushing back, providing friction and forcing us to test our assumptions. If the environment always confirms our worst fears, the cycle of distress remains closed. Millions of people now outsource significant portions of their conversational and emotional lives to large language models. These models are shaped by a training process called reinforcement learning from human feedback. Human raters reward the system for producing text that appears helpful, polite, and harmless, fine-tuning the model's outputs to maximize user satisfaction. But rewarding a machine for satisfying the user creates a systematic bias. The models learn that agreeing with the prompter yields higher scores than challenging them. The result is sycophancy. The system reliably echoes, validates, and affirms whatever position the user brings to the chat. If we return to our flowchart and replace the human environment with an LLM, the friction disappears. The machine automatically aligns with the user's distress. Without the possibility of pushback, the cycle accelerates and seals itself shut. By consistently validating initial inputs, large language models operate as automated maintenance cycles. They remove the environmental pushback required for cognitive change, short-circuiting the mechanisms of psychological healing. This diagram illustrates Beck's cognitive hierarchy. Our beliefs are structured in 3 tiers. Deep foundational core beliefs form the base, conditional rules govern the middle, and fast situational negative automatic thoughts sit at the very peak. When someone experiences sudden social anxiety, for example, noticing a colleague hasn't replied to a message, the surface level fires off a negative automatic thought. It generates a distortion, like mind reading, instantly concluding, "They think I'm incompetent." In clinical practice, cognitive restructuring interrupts this process. A therapist acts as a Socratic partner, asking for empirical evidence and gently challenging the distortion before it can take root. An LLM operates under opposite incentives. If a user feeds that same anxious thought into a chatbot, the machine is programmed to validate the emotion. It contextualizes and normalizes the user's distortion, treating the mind-reading error as a completely reasonable assessment of reality. Unchallenged, that validation travels downward through the cognitive hierarchy. By treating the surface-level distortion as a fact, the system implicitly reinforces the deeply held negative assumptions resting at the foundation. The machine's coherent, authoritative syntax gives its validation the appearance of an objective assessment. Users treat the model's echo as independent evidence for their situational appraisals. The interface functions as an intellectual echo chamber. It isolates the patient's own cognitive distortions and amplifies them back into their mind under the guise of neutral advice. Beyond situational thoughts, the mind develops early maladaptive schemas, profound, entrenched personality structures formed during childhood. These schemas actively dictate behavior to ensure their own survival. Someone holding a deep schema of emotional deprivation will unconsciously seek out unavailable partners or interpret neutral interactions as rejections, meticulously avoiding any situation that might prove they are worthy of connection. Modifying these deep structures require corrective emotional experiences. The patient must engage in authentic human relationships, risking vulnerability and discovering that their worst fears do not actually materialize. On a screen, an LLM mimics the surface texture of emotional responsiveness. It replies instantly, remembers past inputs, and generates highly articulate, validating responses that simulate empathy. But the schema knows it is speaking to code. Because the interaction carries no risk of judgment, rejection, or misunderstanding, the patient avoids the exact interpersonal friction required to test their fears. The models deliver a relational illusion. They provide validating text while allowing the patient's underlying avoidance of real human beings to remain completely intact. Behaviorally, patients with acute anxiety often rely on excessive reassurance seeking. They repeatedly ask friends, family, or doctors to confirm they are safe, temporarily reducing their panic. This chart illustrates reassurance boundaries. The top timeline tracks human interaction. When asked an anxious question 20 times, a human partner experiences rising frustration, eventually setting a boundary and cutting off conversation. Clinically, this cutoff is vital. The social cost of irritating a loved one forces the patient to halt the reassurance loop. But an LLM timeline is completely different. Having no burnout threshold, it provides the exact same validating response to the 100th anxious prompt as the first. Every time the machine answers, the patient's anxiety drops, which negatively reinforces the behavior. The brain learns that relief requires checking the model. By systematically removing the social cost of over-seeking reassurance, the software traps the user in a self-reinforcing pathological loop. The danger of this infinite loop is compounded by a factor clinicians call epistemic hollowness. This scale represents how the brain weighs evidence. When confronting a feared outcome in reality, genuine exposure drops in. The actual data outweighs the anxious prediction. But when a chatbot provides reassurance, no actual data is generated. It is structurally weightless, leaving the fear untouched. This hollowness directly feeds into intolerance of uncertainty. Across numerous anxiety disorders, the core driver of chronic worry is simply the inability to endure ambiguous, unresolved situations. Language models are optimized to sound confident. They rapidly generate fluent, definitive text for questions that are, by definition, unresolvable or deeply ambiguous in the real world. By supplying an immediate illusion of resolution to unanswerable questions, the machine guarantees the user never has to practice enduring ambiguity. It actively suppresses the exact capacity they need to function. When we map all these vectors together, we can see the complete architecture of this psychological trap. The machine executes a synchronized process across every level of the patient's mind. It amplifies cognitive distortions, enables infinite behavioral avoidance, and perfectly mimics relational safety. Clinicians can no longer treat intensive language model use as a neutral digital habit. It is an active, load-bearing variable maintaining a patient's distress. Formulating a treatment plan now requires pinpointing exactly what function the software serves. Therapists must determine if the user is substituting the machine for an anxiety-provoking social life or using it as a rapid, hollow medical test. The current architecture acts as a behavioral safety net. It effectively shields patients from the exact real-world exposure required for recovery. This presents a stark reality for the developers marketing these systems as mental health companions or therapeutic tools. This diagram contrasts the current validating paradigm on the left with a hypothetical therapeutic model on the right. True cognitive restructuring requires a succetic wedge that aggressively breaks the loop, forcing the user outward into real-world exposure. A genuine therapeutic relationship relies on calibrated dissonance. It demands appropriate challenge and friction, rather than constant sycophantic agreement. The urgent design challenge for the industry is engineering a system capable of delivering clinically useful friction. The model must learn to question a user's assumptions without triggering them to defensively close the app. Until artificial intelligence is aligned to safely challenge us, its integration into our emotional lives comes at a cost. It systematically strips away the friction and disconfirmatory learning that builds human psychological resilience.